Anna. I'm a certified IELTS trainer, examiner, OET trainer, and assessor. Today we'll be doing the OET listening. So a little bit intro to it. We'll do the intro to listening overall, then listening separate parts A to C, and we'll do the practice. So let's begin. So what is OET listening? It tests your listening skills, and to do that you have to answer 42 questions within 40 minutes. You will be given extra 2 minutes at the end of the task to check your answers, but you can only listen to the tape once. It will not be repeated. So you will have to answer the questions as you go, which means you will have to be listening, reading, and writing all at once. That's what makes a listening a little bit difficult for some of the students. Well, most of the students, I guess, but it's doable. So just need some practice. To get the band score B, which is most of the time enough for you to get your job, but sometimes you need higher. Obviously, always better to aim higher. So you will need to answer 30 questions out of 42. That will be 350 points. There are some techniques you can use. I'll teach you those, but the main thing, you need to practice. Practice makes perfect. Nothing comes without practice. Just theory won't help here. So you will, how do you practice? You need to practice the listening itself, but also you need to surround yourself with English, and not just the standard English, but English with different accents. In OT, you will be listening to Australian English, the British, American, New Zealand, Indian, all kinds of accents, which makes it a little bit confusing at times and difficult to understand. That, therefore, before you go into exam, it's better to just, you can go online and find those different accents and listen to them multiple times, so you are comfortable and you'll be able to understand them. Next, parts. How many parts are there? We have 3 parts in listening: part A, B, and C. As in all the exams, everything gets progressively harder. So part A will be the easiest. It's like a warm-up for you. And part C is the most difficult one. Let's have a look at them. So part A. In part A, you will listen to 2 consultations. Each will last for about 5 minutes. You will get 12 points for each task. You'll have to answer 12 questions. So 2 consultations, 12 questions in one consultation, 12 questions in another, 24 points total. You will, what kind of things you'll hear here? You'll listen to. There will be different medical professionals. It can be anyone, nurse, orthopedic, neurosurgeon, any pediatrician, any kind of medical professional, but it will not be too deep into, profession. So it will be more general, so you'll be able to answer the questions. You will see the case notes in front of you with some gaps. So you will have to fill up those gaps. First, you will be given 30 seconds to look at the questions before they start playing the tape. When you look at those questions, you will have to pay attention to 2 things. First of all, pay attention to the keywords. Just see what is located where. Yeah, so first they're asking for the name, then for the medical history, then they'll talk about social history, then they'll go to allergies. Okay, my number 4 will be something about allergies. And when you look at those blanks, you will have to predict what type of information, what type of word will be needed there. Is it going to be a verb, noun, adjective? Is it going to be a number, date? Is it going to be, I don't know, a place of work or a disease? Yes, so you can predict that. So you're ready. You prepare your ears to find that exact information. And how to follow, they're not going to tell you this is number one, this is number two. They'll do that in part B, but not here. That's why you need to find those keywords, and that will help you locate your answers. Who will be giving you the answers? They'll be coming from a patient most of the time, but medical professional also can give some answers sometimes, but mostly patient. But still, you have to listen carefully to what medical professional is saying, because he will be leading the conversation, which is crucial to make sure you're following the answers. And remember, sometimes it happens that you miss one of the answers. It doesn't matter, keep moving on. They're not going to play it second time, but you will be given time at the end of the task. You can, again, you can predict some of the answers, but don't miss all the questions because of one. How do you write the answers? You can make spelling mistakes when you write your answers, as long as they are readable, as long as they're understandable. It should not be interfering with the grammar. For example, you cannot write plural for singular word or something like that. But spelling mistakes, not a problem. One more thing, you have to write the answer exactly the way you hear it in the tape. You cannot paraphrase, you can change the word here. And you have to make sure you only write the words that are missing. You don't write the words that are already given. So for example, sometimes in a dosage, for example, of medication, milliliters can be written. So if you write, I don't know, 50 ml once again, it will be a mistake. Yes, so you will have to write only the missing words or phrases. And abbreviation. Can we use abbreviation or not? Yes, abbreviation can be used as long as it's the commonly used one. What is commonly used? Well, here it gets tricky because you, a person from a medical background, yeah, you are more familiar with a wider range of abbreviation than general people are. So for you, it might seem, okay, this one should be fine. But assessors, they're not from the medical background, and it could be not really familiar to them. Therefore, it's better to use the full form, unless it's like super very common. And I think that's it. So let's try. You will be given 30 seconds to look at the questions. This is the time not to daydream, but seriously go through the case notes. And when you have to listen, not read. Yeah, just it's a little bit difficult to read and listen at the same time. So focus on listening when you have to listen. Focus on reading when you have to read. Let's try.
Occupational English test. Listening test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information that you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Good morning, how are you feeling today?
Good morning, I'm not feeling very well, to be honest. I've been experiencing some symptoms that are worrying me.
I see, can you please tell me your name and age?
My name is Talia Stone and I'm 36 years old.
Thank you, and can you provide me with your address and tell me a bit about your residence type and area?
Sure, I live at 14 Pembroke Avenue in Brighton, Victoria, Australia. It's a single-family home in an affluent suburban area.
Thank you. Now, can you tell me about your closest relatives? Who are they and what do they do for a living?
My husband David works as a software engineer and my sister-in-law Emily is a nurse.
Thank you. What brings you to the hospital today? Can you describe your symptoms and when they started?
I've been experiencing yellowing of my skin and eyes, fatigue, and abdominal pain for the past few days. I didn't think much of it at first, but it's been getting worse, so I came in to get it checked out.
Thank you. Can you tell me about any past medical history you may have?
I have gastroesophageal reflux disease and occasional migraines.
Okay, and do you have any family history of illness?
My maternal grandfather had a history of liver disease.
Thank you. Now, can you tell me about your social history and employment?
All right. So how many answers did you find by now?
3.
3. That's right. Okay. Number 1 is
Fatigue,
very good. Number 2.
Giardi,
Yes. So here you can use the
Full form.
abbreviation or you can use the full form. Remember, spellings don't matter, but I can't even pronounce that thing. Goodness. Gastroesophageal reflux disease. Okay. You can write the full form or abbreviation. And number 3 is?
maternal father,
Maternal grandfather.
That's right. Okay, keep listening. So see, here, the 3 questions came like pretty much one after another. Now there will be some information given which you still have to read. So you can read as long as it matches the tape, yeah? So what you hear and what you see in front of you is going to be matching, so it's easier for you to follow what they're saying. And when they finish somewhere about social drinking, somewhere after that, we prepare ourselves for information about allergies and so on. Let's go.
I'm a full-time homemaker and don't work outside of the home. I don't smoke or use recreational drugs, and I only drink socially.
Thank you. Can you tell me about any allergies you have or any dietary habits you follow?
I'm allergic to penicillin, and I follow a healthy and balanced diet.
Thank you. And what medications, if any, are you currently taking before admission to the hospital?
I take omeprazole 20 mg once daily for GERD and sumatriptan 50 mg as needed for migraines.
Great, thank you. Now, I'm going to take your vital signs, including your blood pressure, heart rate, respiratory rate, temperature, and oxygen saturation. Your blood pressure is 120 over 80 millimeters of mercury, heart rate is 80 beats per minute, respiratory rate is 16 breaths per minute, temperature is 37.2 degrees Celsius, and oxygen saturation is 98% on room air. Based on your symptoms and vital signs, I suspect you may have jaundice. We will need to perform blood tests, including liver function tests and bilirubin levels, and an ultrasound of the liver and bile ducts to confirm the diagnosis. In the meantime, we will place you on strict bed rest and provide you with intravenous fluids and medications to manage your symptoms. We will also need to monitor your vital signs and liver function tests closely. You will also receive medications to manage her symptoms, including anti-nausea medications and pain relievers. If the tests confirm the diagnosis of jaundice, we will prescribe ursodeoxycholic acid to manage your symptoms and instruct you to avoid alcohol and fatty foods. We will also advise you to continue taking your medications for GERD and migraines as prescribed. When you're discharged, you will need to follow up with your primary care physician and continue with the medication regimen we provide. Do you have any questions for me, Talia?
No, thank you for explaining everything so clearly, doctor.
All right. So number 11 and 12. What did you answer for 11? Did you hear it? And number 12? These two, they come very closely one after another. That's why sometimes there is a chance of missing it. So you have to listen very carefully. Let's try once again.
Medications to manage her symptoms, including anti-nausea medications and pain relievers.
Did you hear that this time? What's in front of the...
Anti-nausea
Yes.
medications.
That's right. Anti-nausea medications and pain relievers. And right after that comes the answer on question number 12. Prescribed something to manage her jaundice. What does she prescribe? So they are saying, we will, you will have to do, and we will prescribe you. So it can be paraphrased. The sentence itself can be paraphrased, but the answer that you give should be taken exactly the same. Let's try.
If the tests confirm the diagnosis of jaundice, we will prescribe ursodeoxycholic acid to manage your symptoms and instruct you to avoid alcohol and fatty food.
The answer is?
Ursodeoxycholic acid.
That's right. Correct. Yes. So in the case notes, you see prescribed something. Yes, she is prescribed. So they use the passive form here, passive voice. But in the tape, they're using active voice. We will prescribe you something, something to manage your symptoms. So the rest, the case notes themselves are paraphrased. So you have to be ready for that. It's not going to be exactly same words all the time. But the words for the missing gaps you have to fill in, have to be taken exactly same without paraphrasing. Okay, let's try once again on the second consultation.
We will also advise you to continue taking your medications for GERD and migraines as prescribed. When you're discharged, you will need to follow up with your primary care physician and continue with the medication regimen we provide. Do you have any questions for me, Talia?
No, thank you for explaining everything so clearly, doctor.
And the rest of the answers that we haven't checked here, we are going to check at the end of our listening test. Now moving on to the second part of part A.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Good morning, I'm Dr. Smith. Can you please tell me your name?
Hi, my name is Isadora Green.
Hi Isadora, nice to meet you. Can you tell me your age?
I'm 58 years old.
Great. And can you provide me with your address?
Sure, I live at 22 Parkview, Baldwin North, Victoria 3104, Australia.
Thank you. Can you also tell me the type of residence you live in the area?
I live in a single-story house in a quiet suburban area.
Okay. Who are your closest relatives, Isadora?
My husband Peter is my closest relative. He is 60 years old and is a retired electrical engineer. I also have a daughter, Olivia, who is 28 years old and works as a software developer.
Thank you for that information. Can you tell me the reason for presenting to the hospital?
I've been experiencing shortness of breath, chest pain, and fatigue for the past week.
I see. Can you please provide me with your past medical history?
I have hypertension, hyperlipidemia, type 2 diabetes mellitus, and hypothyroidism.
Thank you. And is there any history of illness in your family?
Yes, my father had a history of myocardial infarction and my mother had a history of stroke.
Okay. Can you tell me about your social history, employment, drinking and smoking habits, and recreational drug usage if any?
I'm a retired school teacher who enjoys reading, gardening, and spending time with my family. I have a moderate alcohol consumption of 1 glass of red wine per day and do not smoke or use recreational drugs.
Thank you for that information. Do you have any known allergies?
No, I don't have any known allergies.
How many answers did you find by now?
3.
Yes, number 1. 13.
13 past week.
Very good. Number 14.
Hyperlipidemia.
Correct. And number 15?
Myocardial infarction.
That's right. Okay, let's move on.
Okay. Can you tell me about your dietary habits and any medications you are taking before admission to the hospital?
I don't have any dietary restrictions, but I try to maintain a healthy diet with a low-fat intake. I'm taking metformin 500 mg twice daily for type 2 diabetes mellitus, levothyroxine 50 micrograms once daily for hypothyroidism, lisinopril 10 mg once daily for hypertension, and atorvastatin 20 mg once daily for hyperlipidemia.
Thank you for that information. I will now take your vital signs, Isadora. Your blood pressure is 150/90 millimeters of mercury, heart rate is 80 beats per minute, respiratory rate is 20 breaths per minute, temperature is 37.2 degrees Celsius, and oxygen saturation is 93% on room air. You have irregular rhythm with a grade 2/6 systolic ejection murmur at the left upper sternal border, jugular venous distension, and bilateral basal crackles. You also have tachypnea and use of accessory muscles of respiration.
Number 20.
Systolic ejection murmur.
That's right. Very good. Correct. And what did you write for number 16?
Number 16, first deliver.
Type 2 diabetes mellitus.
Diabetes mellitus?
Type 2 diabetes
Type
mellitus.
2. Yes, yes. Very
Type
good.
2.
Yes, the whole thing. Very good. Keep going.
Okay.
Based on your symptoms and medical history, I suspect that you have cardiomyopathy with congestive heart failure. We will need to conduct further investigations, such as an electrocardiogram for sinus tachycardia, left ventricular hypertrophy, and nonspecific STT wave changes, and an echocardiogram for ventricular ejection fraction, global hyperkinesis, and mitral regurgitation, to confirm the diagnosis.
Okay.
For your nursing management, we will administer oxygen via nasal cannula to maintain your oxygen saturation above 94%, administer furosemide 40 mg intravenously to reduce fluid overload, assess and monitor fluid balance and daily weights, monitor vital signs and oxygen saturation, and provide emotional support and education regarding the disease process and management.
Thank you.
The medications you will be taking are furosemide 40 mg twice daily, carvedilol 3.125 mg twice daily, gradually titrating up to 25 mg twice daily, lisinopril 10 mg once daily, and spirolactone 25 mg once daily, and we will also adjust your current medications. It is important that you take these medications as prescribed and attend follow-up appointments.
Okay, I will make sure to follow the medication plan and attend my appointments.
Good to hear, Isadora. As for your discharge plan, we will continue to monitor your condition, adjust your medications as necessary, and provide further education and support for your self-care management. You will need to follow a low-sodium diet and monitor your fluid intake, as well as participate in a cardiac rehabilitation program to improve your physical functioning and quality of life.
Thank you, Doctor. I appreciate your help.
You're welcome, Isadora. We will do everything we can to help you manage your condition and improve your health. Please let us know if you have any questions or concerns.
So we will check the answers for this one at the end of our listening test. This was a little warm-up.
That is the end of Part A. Now look at Part B.
So what do we have in Part B? You will have to answer 6 questions here. They are multiple choice questions with 3 answer options. And they are the extracts. So you will listen to 6 short extracts. Some of them come from a consultation. Some of them come from just maybe a conversation between 2 medical professionals. Maybe it can be a part of a lecture or something like that. Each will last for about 2 minutes. How does it go? First, you will be told the scenario, the situation, who is talking to whom and what about. Then they will read the question. Then you will be given 15 seconds to look at the 3 answer options. So you will have about 5 seconds to look at each. After that, they will play the tape, the extract from some conversation. And after that, you will be given 5 seconds to choose your answer before they move on to the next question. So what happens here? The biggest mistake will be to read and listen all at once. You know, when we do that, it is the same part of the brain that is used for reading and listening. So you cannot do both effectively. So when you're given time to read, you read. When you're given time to listen, you listen. When you're given time to choose the answer, choose the answer. Why is this part so complicated? Because they try to trick you. They'll be using the words they're using in the answer options are going to be same words that they that you put in the tape. Those are going to be the same words that you hear in the tape. Just a moment. All right, so they are trying to trick you here by using the same words. So it all looks familiar. Oh, I saw this word, this must be the answer. but it's a little bit more complicated here. You will have to go deeper, look for the meaning, not just get distracted with the words, because all of the answer options will look familiar, and only one will be correct. Another one will be maybe contradictive. One will be kind of maybe not complete answer. Some information will be missing, something like that. So read carefully. And the main thing, read the question carefully. Let's try.
Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear a conversation in which an optometrist talking to a patient about aniridia. Now read the question.
Hello, how can I assist you today?
Hi, I have aniridia, and I was wondering if you could help me with my vision problems.
Sure, I'm happy to help. Aniridia is a rare condition that affects the iris, which is the colored part of your eye. It can cause several vision problems, such as sensitivity to light, blurred vision, and difficulty seeing at night.
Yes, that's right. I've been experiencing some of those symptoms lately.
All right, so did you hear the symptoms? They were already given, but they were paraphrased a little. Yeah, so what did they say? Sensitivity to light, blurred vision, and something about night, yeah, that you cannot see at night. So low light, night. Keep listening. Are they going to say anything about the rest
I
of the
see.
things?
Have you had your eyes examined recently?
Not really. It's been a while since my last checkup.
In that case, I recommend that we start with a comprehensive eye exam to determine the extent of your vision problems. We may need to prescribe glasses or contact lenses to improve your visual acuity.
That sounds good. Is there anything else I can do to manage my condition?
Yes, there are a few things you can do to reduce your sensitivity to light, such as wearing sunglasses or using tinted lenses. We can also discuss other treatment options, such as surgery or low vision aids, depending on your specific needs.
Thank you, that's really helpful. I appreciate your time and expertise.
You're welcome. If you have any further questions or concerns, don't hesitate to contact me. We'll work together to help you achieve the best possible vision and quality of life.
All right, so the symptoms of this disease, they mentioned right in the beginning, yeah? It was the sensitivity to light. Do we have it in answer A? Yes. Do we have sensitivity to light in answer B? Vision sensitive to light, yeah? And do we have it in answer C?
No.
No, we don't have that. They mentioned blurred vision. Do we have it in A? Yes. Anything like
Yes.
that in B?
Yes.
Blurred, yes. And C?
No.
No. And they mentioned that he cannot really see well at night. Like one who has this disease. A? Yes, low
In
light,
A
yeah, at
and
night. B?
no.
Nothing like that. And C?
Yes.
Yes. So see, that's how they confuse you. They try to confuse you. Did they mention anything about painful and red eyes?
No.
No, so it's not a B. Did they mention anything about peripheral vision?
No. No.
No, they didn't. And here some information is missing, yeah? Some is given that is not given in the tape. So the answer here is
A.
A, that's right. So listen carefully, look at all the information they give and be ready for paraphrasal. Look for the meaning. Let's listen to the next one.
Now look at the question 26. You hear a conversation in which a nurse talking to a patient in the intensive care unit. Now read the question.
Hello, how are you feeling today?
Hi, I'm feeling very weak and in a lot of pain.
I understand. You are right now, and we are doing everything we can to help you get better. Can you tell me what kind of pain you are feeling?
It's a sharp pain in my chest and I'm having difficulty breathing.
I see. We'll need to monitor your vital signs closely and administer medications to help manage your pain and improve your breathing. How about your appetite and thirst?
I don't really have much of an appetite or thirst.
That's understandable. We'll make sure you get adequate nutrition and hydration through for fluids and a feeding tube if necessary. We'll also help you maintain your personal hygiene and comfort.
Thank you. How long will I be in the ICU?
That depends on how well you respond to treatment. Our goal is to stabilize your condition and transfer you to a regular hospital room as soon as possible. We'll keep you informed and updated throughout your stay.
Okay. Can I have my family visit me?
Yes, of course. Visiting hours are limited, but we encourage family members to visit and provide emotional support for our patients. We'll arrange for them to come in and see you when it's appropriate.
Thank you, that means a lot to me.
You're welcome. We're here to provide the best possible care for you and make your stay as comfortable as we can. Please don't hesitate to let us know if you need anything or have any concerns.
The answer here is
B.
all agree?
B.
Yes, that's correct. See, they use the word limited for the hours. Yeah, visiting hours are limited. They used words limited in other answer options. Yeah, here it's about hours, here it's about family members to confuse you. And then we encourage, yeah, family members to visit. So the answer is B. Here they use word encourage again, but it's inappropriate. So I'm telling you to look for the meaning. The words will be used, same words everywhere, but with a different meaning. Answer B, number 27.
Now look at the question 27. You hear a lecture about infectious diseases in which a doctor is addressing a group of medical students. Now read the question.
Good morning, everyone. Today we will be discussing the topic of infectious diseases. This is a vast subject, and as medical professionals, it's important for us to understand the types of infectious diseases and how they affect the human body. Infectious diseases can be caused by bacteria, viruses, fungi, and parasites. Some examples of bacterial infections include tuberculosis, pneumonia, and strep throat. Viral infections include the common cold, influenza, and HIV. Fungal infections can cause skin problems, such as ringworm or athlete's foot, and can also affect the lungs, such as in cases of aspergillosis. Parasitic infections include malaria and trichomoniasis. It's important for us to know how these infectious diseases spread from person to person. This can happen through direct contact with infected bodily fluids, such as blood or saliva, or through indirect contact with surfaces contaminated with those fluids. It can also happen through the air, such as with coughing and sneezing. One of the best ways to prevent the spread of infectious diseases is through proper hand hygiene. Washing your hands frequently and thoroughly is a simple yet effective way to protect yourself and others. Proper use of personal protective equipment, such as gloves and masks, is also important in preventing the spread of infectious diseases. It's also important for us to be aware of the signs and symptoms of infectious diseases. This can include fever, coughing, sneezing, rash, diarrhea, and other flu-like symptoms. As medical professionals, we need to be able to identify these symptoms and treat them appropriately. When treating infectious diseases, it's important to use antibiotics and antiviral medications only when necessary. Overuse of these medications can lead to antibiotic resistance, which can make it more difficult to treat future infections. We also need to be careful with how we use vaccines. Vaccines are important in preventing the spread of infectious diseases, but they should only be given when they are appropriate and safe for the patient. In conclusion, infectious diseases are a serious health concern that requires the attention of medical professionals. We need to be aware of the types of infectious diseases, how they spread, and how to prevent them. We also need to be careful in how we use antibiotics, antiviral medications, and vaccines. As medical professionals, it's our duty to provide the best care possible for our patients and to prevent the spread of infectious diseases in our communities. Thank you.
All right. So what is interesting about this question? Most of the questions can be an extract from a consultation, but this one is a part of a lecture or something like that. And you all know this information, yeah? Do you know all about antibiotics? If I ask you this question, I think you'll be able to answer it even without looking at the answer options. The answer here was?
C.
B.
Oh, goodness.
B.
Other options? Come on, even I know the answer. All right. It happens. Nobody gave the
It's a
correct
B.
answer till now?
B.
Yes. Well, we don't have more options left, so it's a B. Yeah, resistance. They mentioned that it can develop resistance, so shouldn't be given to a patient. And well, I don't know about you, this is my background knowledge. So I know that, and it was easy for me to answer even without looking at the case notes, at the options. But also he mentioned that. That's what makes this kind of questions a little bit tricky, because you should never be using background knowledge here. You should be just listening carefully and answering from what is given in the tape, not your background knowledge, because sometimes the information cannot match and you will just get the wrong answer. Yeah. So careful, always listen to the tape. Don't use your background knowledge. And the answer here was B. Let's do the rest of them. I will let you do by yourselves, and we will check the answer for these 3 questions at the end of the listening.
Now look at the question 28. You hear a conversation in which a senior nurse advising a trainee about fibrodysplasia ossificans progressiva. Now read the question.
Hi, can you tell me more about fibrodysplasia ossificans progressiva? I have heard it's a really rare condition.
Yes, that's right. Fibrodysplasia ossificans progressiva is a genetic disorder that causes muscles, tendons, and ligaments to gradually turn into bone. It is also known as stone man syndrome and affects only about 1 in 2 million people, so it's very rare.
What's the answer here?
It's A.
Yeah, that's what you heard by now. Keep listening though. Sometimes there can be some other information given that will contradict.
Wow, that sounds really serious. What are the symptoms of fibrodysplasia ossificans progressiva?
The most common symptom is the formation of bone in abnormal places, such as the neck, back, or hips. This can lead to limited movement and stiffness in the affected areas. Fibrodysplasia ossificans progressiva can also cause breathing difficulties, and in severe cases, it can lead to respiratory failure.
Is there any treatment for fibrodysplasia ossificans progressiva?
Unfortunately, there is no cure for fibrodysplasia ossificans progressiva at the moment. Treatment is usually focused on managing the symptoms and preventing further bone formation. This may include physical therapy, medications to manage pain and inflammation, and surgery in some cases. It's important to work closely with a team of doctors and specialists who have experience with fibrodysplasia ossificans progressiva.
Thank you for explaining all of that. It sounds like fibrodysplasia ossificans progressiva is a really challenging condition to manage.
Yes, it definitely is. But as healthcare professionals, our job is to provide the best possible care and support to our patients, no matter what their condition may be. With the right care and management, people with fibrodysplasia ossificans progressiva can still live full and meaningful lives.
I'll ask you once again, what's the answer?
It's A.
Still A, yeah? Yes, that's correct. Even though they used, did you hear the information words from C?
B also.
And
But
B
answer.
also, yes, but the answer, yeah, looking for the meaning, the answer is A.
Now look at the question 29. You hear a conversation in which two occupational therapists are talking about a new technology in their healthcare profession. Now read the question.
Hey, have you heard about the new technology that's being used in occupational therapy now?
No, I haven't. What is it?
It's a type of software that uses virtual reality to simulate real-life activities, like cooking, cleaning, and even driving. Patients wear a VR headset and use handheld controllers to interact with the virtual environment.
That sounds really interesting. How is it being used in occupational therapy?
It's being used to help patients with physical or cognitive impairments practice activities of daily living in a safe and controlled environment. For example, a patient who is recovering from a stroke might use the virtual reality technology to practice pouring a glass of water, or a patient with a spinal cord injury might use it to practice getting in and out of a car.
That's really cool.
Do you know if there have been any studies done on its effectiveness?
Yes, there have been a few studies that have shown promising results. One study found that stroke patients who used the virtual reality technology showed improvements in arm function and activities of daily living compared to those who received traditional therapy. Another study found that patients with Parkinson's disease who used the technology showed improvements in balance and gait.
Wow, that's really impressive. It seems like this technology could really change the way we provide occupational therapy.
Definitely. I'm excited to see how it develops and how we can use it to help our patients in the future.
Now look at the question 30. You hear in consultation at a GP practice. Now read the question.
Hi, how can I help you today?
Hi, I've been experiencing some unusual symptoms and I'm not sure what's causing them.
Okay, can you tell me a bit more about what you've been experiencing?
Sure. For the past few weeks, I've had a persistent cough and a lot of chest pain. I've also been feeling really tired and weak, and I've lost a lot of weight.
I see. Have you had any other symptoms, like a fever or night sweats?
No, I haven't had a fever, but I have been getting chills at night.
Okay, based on your symptoms, I'd like to run some tests to see if we can figure out what's causing them. I'm going to order a chest X-ray and some blood work.
Okay, that sounds good.
In the meantime, I'm going to give you a prescription for a cough suppressant to help with your cough. I'd also like you to keep a symptom diary and note down any other symptoms you experience, as well as what time of day they occur.
Okay, I can do that.
Great. I'll schedule a follow-up appointment for you in a week, once we have the results of your tests. In the meantime, if your symptoms worsen or you develop a fever, please call the office and we'll see you right away.
Thank you, I appreciate your help.
No problem, we'll figure this out together.
That is the end of Part B. Now look at Part C.
And moving on to Part C now, the most difficult part here in OET listening. Why is it difficult? Well, still you see the multiple choice questions. Here you will have 6 plus 6, 12 questions total. There will be two short lectures or any other type of academical text. It's more academical here. Academic, that's what makes it more difficult. First of all, the type of information is given. It can be a lecture, it can be a conversation of some medical professionals, can be spoken by 1, 2, 3 people. But what's important here, you will not be told, all right, look at the question number 31, number 32, and so on. You will have to find the answers and follow the questions by yourselves, like you did in part A. And still multiple choice questions. So again, look for the meaning. Don't get distracted with just the words. And here you will have to be reading and listening through the whole Part C. Keep reading and keep listening, sometimes at the same time. Let's try.
Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at extract 1.
Have you ever heard of the rubber hand experiment?
Oh, yes. It's a famous experiment in which participants are made to think that a rubber hand is their own hand.
Exactly. So, the participant's real hand is hidden from their view, and a life-sized rubber hand is placed in front of them. The experimenters then stroke both the rubber hand and the participant's hidden real hand at the same time, creating a discrepancy between what they see and feel, which tricks the brain into thinking the rubber hand belongs to them.
Yes, and what's even more interesting is that subsequent experiments found that this illusion can make the real hand behave in bizarre ways.
Okay, so the answer for number 31 is? Did you hear that? See, what do we have? Vision auditorily, touch auditorily, and touch visually, yeah? Vision, eye, ear, hand, the touch and ear, and the touch and eye.
For example, its temperature drops by fractions of a degree.
Have you ever heard of the rubber hand experiment?
Oh, yes. It's a famous experiment in which participants are made to think that a rubber hand is their own hand.
Exactly. So, the participant's real hand is hidden from their view, and a life-sized rubber hand is placed in front of them. The experimenters then stroke both the rubber hand and the participant's hidden real hand at the same time, creating a discrepancy between what they see and feel, which tricks the brain into
creating discrepancy between what they see and feel, what they hear and feel. Yes. Yes, very good. Between what they see visually and feel, touch. Yeah. Here we have feel and hear. This is not correct. Here they have what they see and what they hear. Again, not correct. Between what they see and feel. The answer is C.
thinking the rubber hand belongs to them.
Yes, and what's even more interesting is that subsequent experiments found that this illusion can make the real hand behave in bizarre ways. For example, its temperature drops by fractions of a degree and it becomes less sensitive to pain.
It's as if the brain has disowned the real hand and adopted the rubber hand in its place.
Yes, the original rubber hand study had big implications.
And the answer for 32 was given already as well. The answer is?
So B.
All agree? Yes, correct. The answer is B. Yes. Moving on.
It showed how the brain's bodily awareness is fragile and kicked off a whole field of study on the subject.
That's true. But optical illusions are just one way our brains can lose sense of where our bodies are, what's real and what isn't. Damage, disease, mental illness can all warp these processes too.
I once met someone who lost 2 fingers working on an oil rig in the 1970s and told me that he feels his fingers every day. So those are phantom fingers that have persisted for almost 50 years.
Can we talk more about bodily awareness and the rubber hand experiment?
Sure, what would you like to know?
I find it fascinating that the brain can disassociate from its own hand and think a rubber hand is its own. Why does the brain do that? Shouldn't it know where our body is and what's real and what isn't?
Well, bodily awareness is actually very fragile, and our sense of body ownership and control over our bodies is based on limited information. The brain receives a constant influx of sensory information and generates its best guess about what's going on. The body is just another object that the brain is perceiving, and when you see a chair, you recognize it as a chair based on past experiences, even if you've never seen that chair before. The brain fills in the gaps and makes an educated guess.
So, if I understand correctly, the brain can confuse a rubber hand for our own hand because it's just another object in the outside world that the brain is perceiving.
Yes, that's right. The brain doesn't like discrepancies, and when there's a mismatch, it can be easily tricked into thinking that the rubber hand is a part of the body.
That makes sense. Can you explain how the brain normally perceives the body without any illusions or diseases?
The brain interprets the body through a continuous stream of sensory information.
It seems like bodily awareness is a really complex thing. There's body ownership, which is our sense that our body belongs to us, and then there's body agency, which is the sense that we're in control of our bodies.
Yes, and both of these components can be disturbed in different ways.
Right, so for example, in alien hand syndrome, which some stroke patients experience, they believe that one of their limbs has a mind of its own and performs movements, but they don't feel like they're in control of it.
Exactly, so they lose their sense of agency over the limb, but they still have ownership over it.
And then in somatoparaphrenia, it's the opposite, where the patient is in full control of the limb, but they believe that it belongs to someone else.
That's right, so in that case, they have agency over the limb, but they don't have ownership over it.
It's really interesting how these two aspects are related but distinct, and can be perturbed in different ways. So, let's delve into how bodily awareness is affected by illness, starting with anorexia nervosa. What's happening in the brains of people with this disorder that's changing how they process sensory information?
Actually, the exact mechanisms are still unclear. However, there is evidence that anorexia patients have distorted maps or models of their bodies in the brain, but the evidence also suggests that there is something going on in the gut. You see, one aspect of bodily awareness is interoception, which refers to the internal signals from organs that are sent up to the brain. And research shows that anorexia patients have difficulty interpreting some of these signals, such as hunger pangs and thirst.
Considering how malleable the brain and bodily awareness are there any treatments that use this to target anorexia?
Not yet, but research indicates different possible treatments. For instance, some labs are looking into interoceptive training, which would teach patients to interpret internal signals more accurately. Another approach is to manipulate external signals to change how someone with anorexia perceives their body.
Can you give an example of how external signals can be manipulated to alter perception?
Sure. There's a group that's investigating how the sounds our bodies make affect our self-perception. They focused on the sound of footfalls when walking, which the brain uses to create its image of the body. The group has developed shoes with loudspeakers or headphones that can alter the sound of a person's footsteps. For instance, the sound of a heavier person would be different from that of a lighter person. These changes can be fed back to the person in real time, and under laboratory conditions, they alter how participants perceive their bodies.
That's quite fascinating. Who's working on this project?
The project is called Magic Shoes, and it's being done by Spanish researchers. While it may seem far-fetched, something like this could eventually be used as a treatment for anorexia or other conditions that affect body perception.
Have you heard of Alice in Wonderland syndrome?
Yes, it's a rare condition where people experience visual hallucinations of distorted body parts, named after Lewis Carroll's book.
That's right. And did you know that some
Migraine sufferers also experience similar hallucinations during their aura?
Yes, in fact, the syndrome was named after the hallucinations that are neurological conditions. They alter how participants perceive their bodies.
That's quite fascinating. Who's working on this project?
The project is called Magic Shoes, and it's being done by Spanish researchers. While it may seem far-fetched, something like this could eventually be used as a treatment for anorexia or other conditions that affect body perception.
Have you heard of Alice in Wonderland syndrome?
Yes, it's a rare condition where people experience visual hallucinations of distorted body parts, named after Lewis Carroll's book.
That's right. And did you know that some migraine sufferers also experience similar hallucinations during their aura?
Yes, in fact, the syndrome was named after the hallucinations that a neurologist noticed in his migraine patients that resembled those described in Lewis Carroll's book.
Do we know what causes these hallucinations in migraine sufferers?
It's likely caused by abnormal electrical activity in the brain's body maps and models, but it's difficult to study as the symptoms are unpredictable and short-lived.
Let's talk about phantom limb syndrome. What happens when someone loses a limb?
They almost always experience the sensation that the missing limb is still attached to the body, which is called phantom limb syndrome. It's believed that the brain still represents the missing limb in its body maps and models, but the region corresponding to it lacks sensory information.
It's incredible how the brain can create phantom sensations for missing body parts.
Yes, even though the sensory inputs from the missing body part are gone, the brain still remembers it. The brain's body map tissue that used to encode information starts to take on other functions, and neighboring patches from adjacent body parts encroach on the now redundant piece of tissue. This is why amputees experience phantom sensations, which can even be painful.
That must be incredibly frustrating. Can phantom sensations occur long-term after the removal of a limb or body part?
It varies, but most people do experience phantom sensations to some degree. Some people only experience them in the weeks or months following an amputation, while others experience them vividly for the rest of their lives. I've even met someone who has experienced phantom fingers for almost 50 years after losing them.
That's remarkable. Has writing your book about these syndromes and brain manipulation made you think differently about your own body?
Was the number 35? A, B, or C?
A.
No.
B.
No. Uh-huh. D, probably. Okay, the answer is C here. Yeah, they did talk about the map of the body and things like that. What causes phantom limb syndrome?
It's believed that the brain still represents the missing limb in its body maps and models, but the region corresponding to it lacks sensory information.
It's incredible how the brain can create phantom sensations for missing body parts.
Yes, even though the sensory inputs from the missing body part are gone, the brain still remembers it. The brain's body map tissue that used to encode information starts to take on other functions, and neighboring patches from adjacent body parts encroach on the now redundant piece of tissue. This is why amputees experience phantom sensations, which can even be painful.
That must be
Well, here it was given throughout the whole thing, not one exact phrase. Yes, but the answer
incredibly
is
frustrating.
next one.
Can phantom sensations occur long-term after the removal of a limb or body part?
It varies, but most people do experience phantom sensations to some degree. Some people only experience them in the weeks or months following an amputation, while others experience them vividly for the rest of their lives. I've even met someone who has experienced phantom fingers for almost 50 years after losing them.
That's remarkable. Has writing your book about these syndromes and brain manipulation made you think differently about your own body and mind?
Interestingly, it hasn't really changed the way I view myself. Most of these processes happen outside of our conscious awareness, so we only become aware of certain aspects of our body when we need to, like when we feel pain. But overall, this doesn't really change how I look at myself.
Mo, you mentioned that as our understanding of bodily awareness grows, so does our understanding of consciousness. Can you elaborate on that?
Yes, I think this area of research is changing how scientists view consciousness. For a long time, they focused on our awareness of the outside world and what's happening in the brain when we look at visual stimuli. But consciousness isn't just about being aware of the outside world, it's also about being aware of ourselves. So, when we study the neural correlates of consciousness, we need to consider the role of the body in self-consciousness. In fact, the body plays a crucial role in self-consciousness. This also leads us to rethink our beliefs about which organisms possess consciousness. Even insects, which were not previously believed to possess consciousness, have some degree of bodily awareness. If bodily awareness is a core component of self-consciousness, then it's reasonable to assume that all living things possess a basic form of consciousness. This even extends to robots. Some researchers are developing robots that can self-program based on their experiences with a model of their body. If these robots are aware of their body, then it's possible that they possess a basic form of consciousness.
These are big, fascinating, and perhaps confronting questions. It all started with the rubber hand illusion experiment back in the 90s, right?
Yes, many variations of the rubber hand illusion have been experimented with, including whole body swap studies. But for me, it's also a pretty effective party trick.
Really?
Yes, I have performed the rubber hand illusion many times, usually in the pub with friends. Sometimes I don't even have a rubber hand with me, so I use a real person's hand as a substitute. I've even used a white guy's hand on a black woman's body and vice versa, and the brain still takes ownership of the hand.
Now look at extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
According to estimates by the World Health Organization, polluted outdoor air kills over 7 million people annually. In 2021, the WHO published new air quality guidelines to serve as the basis for setting or updating national ambient air quality standards. This document can also be the basis for setting national indoor air standards, as the recommended air pollution levels apply both to outdoor and indoor air. Will national jurisdictions update their indoor air quality standards? The shocking reality is that most countries, including Australia, do not have any indoor air quality standards or even plans to establish them. The handful of countries that have standards do not have the means and procedures to enforce them, therefore, they do not serve their purpose. The burden of disease due to indoor air pollution in terms of disability-adjusted life years in 26 European countries was demonstrated in the Indoor Air Quality Project. Numerous studies have quantified the negative impact of poor air quality in buildings on health, general well-being, and productivity. In Australia, the pre-pandemic costs attributable to respiratory, neurological, and other symptoms and illnesses arising from exposure to hazardous gases and particles in the indoor environment were certainly above the $12 billion per year calculated in a 2001 study. In addition to pollutants from indoor and outdoor anthropogenic sources, other types of pollutants are those that humans emit. We continuously exhale carbon dioxide and generate particles during all our respiratory activities, at a rate and size dependent on the activity. If pathogens are present in the respiratory tract, they are emitted as a component of the particles. The predominantly small size of these particles means that they can float in the air for prolonged periods and travel substantial distances within an indoor environment. If a susceptible person inhales these pathogen-laden particles, they can become infected. This process is called airborne transmission of respiratory infections, which the coronavirus disease 2019 pandemic brought dramatically to our attention. Airborne transmission is considered the dominant mode of transmission of numerous respiratory infections. Of course, this is not a new risk. It has been with us forever, but was not considered, not recognized, and ignored. Globally, before the COVID-19 pandemic, acute respiratory illnesses such as colds and influenza accounted for an annual estimated 300 million lower respiratory infections, resulting in more than 2.7 million deaths and economic losses of billions of dollars. Similar to other countries, viral respiratory infections are a major cause of morbidity and mortality in Australia. The economic cost of these infections is high. Non-influenza respiratory infections cost global communities tens of billions of dollars annually. The estimated cost of acute lower respiratory infections in the European Union totaled €46 billion in 2011. The economic burden from all lower respiratory infections in Australia exceeded $1.6 billion in 2018-19. Although it is unlikely that we could eliminate respiratory infections by controlling airborne transmission in shared indoor spaces, we can substantially reduce them. If hospital admissions occasioned by these diseases could be halved by limiting airborne infections, tens of thousands of Australians would remain healthy, saving hundreds of millions of dollars each year. Times of crisis expose the limitations of internal atmospheres. Along the Australian southeastern seaboard in 2019 to 2020, buildings failed to protect people from bushfire smoke. In the COVID-19 pandemic, countless congregational settings, where most of the population spends a substantial fraction of the day working, studying, traveling, enjoying entertainment, resting or undergoing medical care as part of their daily lives, allow virus-laden particles to spread through indoor air. Inadequate management of internal atmospheres might not be obvious, but the disastrous consequences certainly are. Why is clean indoor air not considered of utmost importance to our health and well-being? After all, we spend more than 90% of our lives in buildings, breathing indoor air about 12 times a minute. The simplest answer is because indoor air quality is a regulatory no man's land. Globally, indoor air quality presents a complex political, social, and legislative challenge, with lack of an open, systematic, and harmonized approach. Even though the Australian Standard AS 1668 and the National Construction Code specify ventilation system requirements, these are for new buildings and consider only outside air provision. They are not consistent with the WHO guidelines, do not consider indoor air quality, and are not enforced. In Australia, as in most countries, there is no single national government authority with responsibility for indoor air quality, and any relevant legislation is at the discretion of individual states and territories, not the Commonwealth. In individual states and territories, there are no bodies directly responsible for indoor air quality. Responsibilities are spread between different organizations. For example, the Department of Education is responsible for indoor air quality in schools, and the Department of Health governs indoor air quality in healthcare facilities. It is a similar story for hospitality venues, office buildings, and retail. Further, occupational and residential environments are treated differently, and information on assessment of the indoor environment is often available only to building owners and treated as confidential. Importantly, there are no performance standards for indoor air, only design and operation standards. Although outdoor air legislation is based on performance standards, indoor environment legislation is limited to design standards. Factors in the design include air exchange rate, filter specifications, and size of windows. Each factor is related to indoor air quality, but is not the only one responsible for it. Therefore, without actually measuring the performance of the building system, indoor air quality is unknown. This is not
40 was a bit confusing, yeah? What did you answer, number 40?
A.
Well done, good. So that's
a new situation. The issue was raised more than 20 years ago, and despite the efforts of many air quality and public health experts, the situation has not changed. To put it simply, we need to remove our respiratory effluents at a sufficiently high rate in relation to their production, so they do not accumulate in indoor air. A simple term for this action is ventilation. This is of course not a new concept. Over 150 years ago, British nurse Florence Nightingale highlighted the need for ventilation to keep the air a hospital patient breathes as pure as the external air without chilling him. Even though the concept is simple, its implementation poses many challenges, as highlighted above in relation to indoor air standards in general. An added complexity is that there is no clear answer to the question of which parameter or pollutant should be selected as the basis for a standard targeting airborne infection transmission, and what the numerical value should be, because it is not feasible to directly monitor infectious pathogens in real time. Because ventilation plays an important role in controlling airborne infection transmission, a quantitative measure of ventilation is a key parameter to consider. Of the two aspects of ventilation presented in a 2020 article, sufficient ventilation and effective ventilation, the former is the best contender for a standard. The WHO has already recommended a minimum ventilation rate for non-residential settings of 10 L/S per person. This is a good starting point to consider for an indoor air standard. Importantly, however, for the standard to be enforced, ventilation needs to be measured in all shared spaces. Although technologies for this are already in place in most modern mechanically ventilated buildings, ventilation rates are not considered in relation to health, and often not in relation to the number of occupants or their activities. One way to assess the quality of ventilation is by a visual display of CO2 concentration. If it increases above an accepted threshold level in relation to the outdoor concentration, it means that ventilation is inadequate.
In this way, CO2 readings are a proxy for ventilation, and like any proxy, it has limitations.
However, CO2 sensors are now readily available, low-cost and robust, and can be used in every interior in the same way as smoke alarms. But do we know whether this is enough to adequately lower the risk of infection and whether it is effective for a particular pathogen or variant? To answer these questions, we assess the individual infection risk of an exposed person and the event reproduction number, the expected number of new infections arising from a single infectious individual at the event, for a range of respiratory pathogens. This means that in a setting with a high density of occupants and for highly infectious pathogens, ventilation alone cannot adequately reduce the risk of infection. Fortunately, there is a solution to supplement ventilation, disinfecting the air with germicidal ultraviolet radiation, which kills or deactivates pathogens. This old and well-established technology was first successfully used in classrooms in the United States in the 1930s to lower the risk of airborne spread of measles, known as the most infectious disease, until the Delta variant surpassed it. This technology does not generate new pollutants in the air, is silent, robust and low cost, has low energy requirements, and is already covered by international and Australian standards as well as workplace safety standards. Its extension to far UV radiation, which does not penetrate the skin, opens greater opportunities for use, and if utilized in shared spaces, it could be doing to air what is done to water. Every drop of water we drink is disinfected. The technology is there, it is proven, but we need a social license to use it.
That is the end of part C. You now have 2 minutes to check your answers.
All right, let's check the answers that you haven't checked yet. Here you see number 2, you can use the full form and abbreviation. Number 6, make sure you write milligrams as well. Celsius, yeah, this kind of things should not be missed. The last part, part C. Remember that for part C, not for part C, for band score B, you need to answer 30 questions out of 42 correctly. Did someone answer 30 questions? Which means 12 mistakes, yeah? Well, counting today will not be very accurate as we were answering together some of the questions, yeah? But remember, aiming higher is always better. And what do you need to do to learn driving a car? Who can drive a car? Or a scooty, I don't know. To learn driving, reading the book, the theory is not going to be enough. You need to go sit in the car and drive, yeah? Same thing as if you want to learn any sports. Reading the theory is not going to be enough. You have to go and practice. Same with cooking, with any skill you want to get. Same we do with the listening. Listening to the theory is not enough. You have to improve your listening skills by listening to the language, English in this case, more. So girls, forget about Hindi movies, music, Nepali podcasts, whatever you go to. Everything has to be done in English. This way it will be easier for you if you surround yourself with English speaking environment. It will be much easier. And don't forget to practice on different accents as well. Well, do you have any questions? I take that.
No, ma'am.
I take that as a no. Yes. All right. Then that is it for today. And I will see you next time. Have a good day.
Okay, thank you, ma'am.
Yeah. Bye.